Welcome to Biztech's Health and Wellness Show. Today we feature the Association of Private Hospitals of Malaysia, which is more commonly known as APHM. This is an association representing private hospitals and medical centers in Malaysia and has been in existence since 1972. It currently has over 100 members spread throughout Malaysia. Now, here to tell us more is its president, Datuk Dr Kuljit Singh. Now, welcome to the show, Datuk.
Hi, thanks for hosting me, Brian.
Now, Dr. Kuljit, can you give us an overview of the APHM and specifically what it does?
Okay, as you said, APHM was first formed in 1972. Today we got 152 members. And these are all hospitals which have a hospital license registered with the Ministry of Health. In Malaysia, there are 210 plus private hospitals. But out of the 210 private hospitals, 152 of them are our members. The rest of them, which are not our members, are most likely small shop lot hospitals, which are not our members as yet. But anyhow, we do represent every private hospital that's there in the country. And we are basically association representing private healthcare, typically for hospitals. And we form one voice in terms of negotiating with the government in terms like what we have right now with COVID. We find that we significantly play a very important role as a link with the government in terms of managing different aspects of the healthcare modules that the government is now looking at, particularly in the pandemic. So this is a very good example. When it comes to public-private partnership, APHM plays a major role in it.
Okay, I want to drill down a little bit into that because that is such a crucial role. Could you walk us through and tell us what was your role with, for example, for a start, the vaccination process, and also in terms of consulting the government when this whole COVID situation hit the world?
To start with, when COVID came into existence last year, the first thing that the private hospitals offered to the government is that we were willing to do testing for them. Testing for those who are going to pay for testing, because we were willing to do 24 hours testing for COVID. We started with the RTK, and then of course, within a month or two, we started the PCR testing in almost every emergency department in the private hospitals. We were not treating COVID patients the entire last year until January this year, when the government decided that the private hospitals should start treating some COVID patients for paying patients. Because the government felt at that point of time, when the numbers were actually quite low, comparatively speaking, that there were a lot of patients that were going to the government sector, but they could actually pay for treatment. So we took up those patients who could pay. And there was quite a substantial amount at that point of time. Of course, today we have no comparison because we are looking at very huge numbers, and the majority of the patients are now in government side. When the vaccines came into play in February this year, the first step we did was we told the government that we will take up the private healthcare vaccination program. Initially, the government was to vaccinate everyone, including the private healthcare, but we told the government that we will look after ourselves, just provide us the vaccines, and private healthcare, private hospitals will vaccinate our own private healthcare workers. And that was a good start for us because we picked up a lot of aspects of vaccine. And then in the month of May, or end of April and May, we started the public vaccination program for the government through My Sejahtera. So right now, almost every big private hospital has got a public vaccination center using the My Sejahtera application. We also send our staff to the mega vaccination centers in Setia Alam, in KLCC, and maybe one or two more to assist them in the vaccination program. So we are working in this partnership in COVID in various levels. Now the most recent thing that we are doing now is we are accepting decanted non-COVID patients from the government hospitals, which just started a couple of days ago, so that we can enable the government to facilitate treating more COVID patients in their facilities. So we have been working in very good partnership with them for the last 1 year or 1.5 years, and we are going along as the need arises.
Now, Doc, I just got my vaccination 2 hours ago. And one of the things that is, I think, has facilitated the vaccination process and also the escalation in numbers, I think we now do over 400,000 a day, is the fact that the government opened it up to the hospitals as well as the private clinic. I went to a private clinic that was very close to me. I was in and out of there, including rest time, of within less than 28 minutes. So why do you think that it took so long for the government to actually expand the process? Because vaccination is the key for us to really combat the situation.
To be fair to the government, because I have been having a lot of talks with YB Khairi Jamaluddin since the beginning of the vaccination program, there was definitely lack of vaccines that were sent to Malaysia and many of the other Asian countries. So we had very little vaccine, and it was not possible at that point of time to disseminate vaccination program broadly. It was prudent that the vaccination was only given by the government facilities to start with. The first phase was for private and public healthcare workers, which was the right thing to do. And then subsequently for the more vulnerable groups, which the government actually started to do on their own with our assistance in assisting them in their centers. The basic reason why they couldn't give it is because there were lack of vaccines. We cannot compare what was going on in the United States or even in the United Kingdom, because in many parts of Europe, they are manufacturers of vaccines, and of course, for the right reason, they would probably vaccinate their own people first.
Yes.
So the scarcity of vaccines distributed over the globe was very much desirable. So right now, from the month of July onwards, we have seen an increased load of vaccines being sent to Malaysia. So hence, the 500,000 number is possible, and more are joining the workforce of vaccinating, including the private sector.
Now, as you mentioned, Doc, the government has started sending non-COVID patients to the private institutions who are your members. How does that work out in terms of the financing? Who pays for this?
Okay, there are pre-agreed costs that the private hospitals and the Ministry of Health has agreed upon. The payment, if the patient is decanted or transferred from a government hospital or private hospital, it is paid by the government. But the amounts that we have agreed are very much on a discounted rate, because it is not our intention in the private hospitals to make money, to make profit out of this. Our mere intention is to help the government to decant and to create space for the patients who have COVID to be treated in the public sector. So it is all fully paid by the government, but it is kept regulated on a pre-agreed price. So we are happy to do it. Some of the additional costs would be absorbed by the private hospitals as a service to the government and to the people. But we are just probably getting enough to cover our costs to treat these patients when they get decanted to a private hospital.
And obviously what's going to happen is it is going to take a tremendous amount of stress out of the public system itself. Now, because then the public system is now currently overwhelmed. Now, can you share with me, because you have been both an academic before, as in a teaching hospital, as well as in government service, has the pandemic exposed any gaps in our healthcare system?
I think one of the biggest things that we have seen as far as gaps are concerned is the collaborative efforts that we should have had between the public and private. We have seen this, that a lot of patients wait for long periods of time in the public sector to get themselves treated, to get operated, and even to get for a simple medical imaging in a public sector can take a long time. At the same time, you have a lot of facilities in the private sector that are found to be vacant after hours, which the government can actually tap. So right now, the government has enhanced buying services from the private sector, which has actually been in existence even before, but it's never been done in a big way. So I think this is something that we have learned through the pandemic. Right now, as we speak, patients are being decanted to the private hospital. And now we understand what are the gaps, what are the shortcomings. And I think after this exercise, I see that in the future, a lot of services can be bought from the private sector, which will ease the government sector, the public sector healthcare service, which will enhance better delivery of care to the patients in the public sector. So I think these were the gaps that we didn't realize. But COVID, as I always say in most of my forums, there's always a silver lining for everything that happens.
So you brought up a very interesting point, because obviously now you've identified an opportunity for unused capacity in the private sector to be utilized by the public sector. But there's also always a question of cost. How is that going to play out in the national healthcare budget moving forward? Because one of the gaps that is probably right now being exposed is the fact that perhaps we could have a slightly underfunded healthcare system in the public system.
Well, I think the important thing that we need to look at is, and the question that we need to ask, how much does it cost to fund a patient in the public sector? Because we don't have those kind of figures. If you're going to go for the appendectomy, or you're going to go for cardiac surgery in the public sector, how much does it really cost? We do not have those kind of figures. But in the private sector, we can tell you through itemized billing exactly how much a medical procedure or treatment will cost. Now, in our belief that, you know, we in private sector will definitely do our costing in a very much regulated, because we do have to make certain amount of profit in our system, and at the same time deliver the best healthcare, because patients are paying. There should be value for money, there should be patient satisfaction, there should be good outcomes. All of that is calculated in our bill. So definitely there is a time that we need to sit together. Will it be more cost effective that certain procedures can be done privately, and probably the government may save more money by buying some of our services instead of they building more hospitals, trying to fund manpower, trying to use the capital expenditure to build more and more government hospitals, but not able to sustain good human resource like doctors and specialists and the rest of it, trained doctors and specialists, for example. So there are a lot of these discussions that hasn't been answered. We have a lot of private hospitals which are probably capable enough of taking up some of that patients in the public sector. And in the long run, probably the government will save a lot more money.
Now, Dr. Kuljit, you brought up a couple of really good points that I want to drill down further. But the first thing I want to talk about is, since we're on the topic of cost, is healthcare inflation. On the private side of healthcare, in the last decade, healthcare costs have been increasing by double-digit annual numbers. Now, most Malaysians are not insured or underinsured, and that is one of the challenges of the public health system, because the public health system, on the other hand, is little or no cost to the patient. Now, what's the way forward? Why is there so much of healthcare cost increase in the private sector?
Healthcare in general is not cheap. It is not cheap in the government and it's not cheap in the private. The only difference is if you get treatment in the government, it is not free. The government is paying for it.
Yes.
And the cost that they're paying for it is probably equivalent to what we pay in private, or probably even more, because the system of procurement may differ a little bit from what we do in private. So there are different layers of how procurement is done in the government sector. But leaving that aside, all medical equipment, medications that we get, both public and private sector, it is all procured internationally. We do not have a large local manufacturing source. Like if you were to buy a CT scan machine, MRI, medication, everything is procured internationally, and that all depends on what kind of exchange rate we're talking about. So when the exchange rates are not favorable, and as time goes by, medical equipment, medications do get expensive in several folds. So what CT scan machine that you have bought 10 years ago and what you're buying today, the cost is extremely different. So when you look at that, it is very difficult to control the inflation. It is not that the private sector is trying to make more money. We are probably having the same margins, but at a higher cost because of the healthcare globally has become expensive, and it will become expensive. And as I said, it very much depends on what kind of exchange rate you're doing. Unless you have got homegrown medical equipment, medical medications that you're having in your own country. For example, like in India, like China, they have a lot of homegrown technology that you buy locally, that you don't have to rely on buying equipment and medication from overseas.
Now, Doc, then is that the way forward for Malaysia in terms of cost containment? Because you use India as an example. Some of their pharmaceuticals are a tenth of the price of what they would cost in Malaysia.
Right. So that's why the cost in India and also other parts of the world, when they have their own medical industry, they can contain the cost quite reasonably. But having said that, we have seen medical tourists in 2018 and 2019 flocking more to Malaysia than the other neighboring countries. We saw a sudden surge of medical tourists choosing Malaysia over the other so-called well-established medical tourist destination. And the reason then we asked medical tourists why they picked Malaysia is because they found that treatment in Malaysia was more cost-effective, which a Malaysian will not be able to appreciate it, but a medical tourist is able to compare what they pay in a neighboring country and what they paid in Malaysia. We were far more affordable, comparatively speaking. That itself is a testimony that we are not as expensive as how we may think we are. But of course, to a Malaysian who's uninsured, paying out of pocket, it may seem to be expensive in the private healthcare.
Now, Dr. Kuljit, on the topic of medical tourism, and obviously we're talking about pre-COVID numbers, where were the bulk of the patients coming from for your members?
Okay, we largely saw patients from Indonesia. We also saw patients coming from Bangladesh, from India, and then we also had some flow from China, not in a big number. We had medical tourists even coming from Europe and Australia for cosmetic surgery in Malaysia. But the large group was actually Indonesian. So they basically used to go to many parts of other areas within our country. And but they certainly felt that Malaysia was a better destination in terms of cost and quality of healthcare. Quality could be equal, but it was more cost effective coming to Malaysia. And the other thing that Malaysia had a bit of an extra edge with Indonesia is our connectivity increased very well in the last 10 years because of airlines like AirAsia flew directly from many cities in Indonesia to Kuala Lumpur. That made a huge difference to Malaysia as far as Indonesian medical tourists were concerned.
And for your members, is medical tourism a significant chunk of their business today, pre-COVID? And again, pre-COVID, because I think post-COVID will probably see a return to those pre-COVID sort of numbers once things settle down. But we're in an abnormally right now.
Well, many hospitals, we had close to 50% or probably even 60% of medical tourists, especially in Malacca and in Penang. The other hospitals in other areas in Kuala Lumpur had about 10 to 20% of medical tourists. So it varies from a hospital to hospital. You must remember some of the private hospitals in Malaysia were dominated by the local crowd, and there was not much of space for medical tourists. But there are also some private hospitals that they were designed specifically for medical tourists, as they could see the numbers going up. So we definitely picked up very well, particularly in 2018 and 2019, and we projected 2020 to be a booming year for medical tourism. But unfortunately, we had another uninvited guest called COVID.
Yes, unfortunately. Now, what I want to zoom in on the medical profession itself and the APHM. What are the key things that are facing the profession right now, and also your members? One of the key things you mentioned just now is, which you touched on briefly, was really the quality of the human capital from the government sector, and there seems to be a mismatch between demand and supply of medical professionals. Could you kind of elaborate on some of the challenges facing your profession right now?
Well, medical profession would be mainly two categories. There would be specialist and nursing. Well, a lot, I would say 95% or 90% of the medical specialists who are working in private had worked in the government service. We were trained in government service and then we served, and then we came out and started practicing in the private sector. That gives a little bit of a constraint to the government because there is a huge mismatch in earnings. The government is not able to give that kind of earning power to the public sector specialists. Hence, there is a little bit of a brain drain. But having said that, the government now has opened up that the government servant, a government doctor, a government specialist is allowed to also spend some hours or some days in the private sector, and which is actually quite good. So there's a little bit of containment of specialists leaving from their sector to our sector. Nursing can be a bit of an issue because even in the private sector, we cannot match the kind of packages they get in the Middle East. A nurse that gets 3,000 to 5,000 in a private hospital may get up to 12,000 to 18,000 ringgit per month in a Middle East hospital without tax. So we do lose a lot of nurses to the Middle East, and that becomes a huge concern to us. Not so much with the specialists, but I think the nursing can be a problem sometimes because we are not allowed to take any foreign nurses at this point of time. We have to use local nurses.
Now, Doc, the training of future specialists is also a big factor because, especially given this contract doctor issue, which is a hot potato right now, could you kind of give us a perspective? Because one of the key issues that they talked about was really the fact that their ability to get specialist training is basically cut off because they're on a contract with the government.
Because the systems they are in place are not in tandem with the processes that they have decided on the other end of the whole ecosystem. The systems dictate that in order to be a specialist or to do any kind of specialization in our local universities, you will have to be a full-time doctor in the Ministry of Health or probably even in the university. But let's talk just about the Ministry of Health. You need to be permanent before you can get a scholarship that is kind of forced upon you, because with the scholarship from the Public Service Department, you are then bonded to work for the government about 5 to 7 years. So that is a pathway that has been there for time immemorial. But on the other hand, the government has then decided that we are not going to give permanent posts to everyone. Some will have permanent posts and some will be on contract. So that's where the disjoint will occur. The ones with permanent posts will have an opportunity to become specialists, and a huge chunk of them are on contract. So they have to make a decision that either you give long-term contracts and allow contracts or medical officers to pursue postgraduate, and in order so that they can also become specialists. So that's the disjoint that they are still discussing and how they are going to do. Are they going to give long-term contracts, or are they going to allow people on long-term contracts to take up specialization, to forego that criteria that have been there for many years? I came through an old system that everybody got permanent jobs 20 years ago when we joined as medical officers, and we were all on pensionable schemes, whichever way you look at it. And our career pathways just moved on as we went along, but it is not the case right now.
But is there a role then for APHM and its members to play in the training of specialists? Because the problems also lie in the fact that given the pipeline and given things that we are short of specialists in certain key areas in Malaysia, we may have a problem 10 years down the track with a lack of specialists given our size of our population.
There are two private entities in the private healthcare system that have already started training specialists. One is the KPJ University, which train doctors into certain specialized areas. And then we also hear that Sunway has started a program in this specialization a program whereby doctors can get themselves specialized, but it's all done in a very small way. The problem in Malaysia is not like the United States, whereby in the United States, they have got huge research university hospitals, research branches with training programs which are privately owned or missionarily owned, like the Johns Hopkins and the Mayo Clinic and Cleveland Clinic. They work on a very different concept where it is privately owned, but they get a lot of grants from the government to run training programs. So it is amalgamated together where you can, it is a private entity, but become specialists. So for us to reach to that level is going to take a lot of time because private hospitals may not have a complete case mix to train a specialist to the level comparable to what we have in the government sector. So when I got trained as an ENT surgeon in the government sector, I was trained in University of Malaya for 4 years. I was exposed to a big amount of case mix in order for me to have adequate exposure to be a specialist. So that are the concerns in the private hospitals in Malaysia because we may not have that. But I believe as we go along, we should be able to attain such kind of a level that we could be comparative to what you do in the university in the private sector, public sector, sorry.
Now, I want to talk about the digital health because this pandemic has really then opened the floodgates in terms of telemedicine and so forth. So how are your members then evolving and offering new services to take advantage of technology?
Telehealth, it's a very good platform for consultation with patients, particularly when there is difficulty for patients to meet the doctor because particularly now with the pandemic, it becomes even more challenging. But having said that, there are limitations in telemedicine. When you look at medicine, medicine is not comparable to e-commerce. In e-commerce, you can buy a product online, pay through credit card, and then you get your goods or your purchases delivered to your doorstep. But in healthcare, you're limited. Number one, if you want to consult a patient for the first time and you have no ability of examining the patient or investigating the patient, then it is very difficult for a doctor to come up with a diagnosis and then even prescribe medication. So medicine is a bit different because if I just sit and talk to you and listen to your symptoms, it is not going to be good enough to come up with a diagnosis. If you are a follow-up patient, then again, it depends. If you have seen me yesterday and you have got further questions to ask me, yes, you can log on and we can continue our consult in terms of question and answers. But if you have change of symptoms, then again, I need to examine you again. What was yesterday, it may not be the same today. Again, it will be wrong for me now to tell you, increase your medication, decrease your medication, add on another medication because I've not examined you. So there are limitations when using telemedicine in these terms. Many people think that telemedicine is the same like e-commerce. No, it doesn't work that way.
Yeah.
So we need to understand that, doctors need to understand that, the patients need to understand that having a 20 minutes consult, only talking about your symptoms, and then the doctor will send you an email, print out the prescription, go to the pharmacy and get your medication. It doesn't work that way.
Now, I want to come back to APHM and and ask you, what are your for you and your executive team at APHM? What's the goals and plans moving forward for APHM?
I think the most important thing that we are looking at is that we want to work closely with the government. We know there are a lot of smart partnerships that we can do with the government. Particularly now we can see how important working together will make a lot of sense. So APHM has always maintained this, that at any time there's any collaborative effort with the government, we should be able to work it out seamlessly to help both parties. But at the same time, we are very concerned sometimes the government has got very rigid regulatory effect to the private sector, which sometimes can make it difficult for us to function. But in our last couple of years, we found that our collaborative effort has made us understand that regulatory is actually good for the patient in terms of patient safety. Many years ago, when there was no Private Healthcare Facility Act, there was not much of patient safety elements in the private healthcare. Today, we have a lot of patient safety elements within the private healthcare, which is regulated by the government. But we are more concerned sometimes when the government tend to encroach in areas of costing, charges, which sometimes can strangulate our businesses because they may not understand that we survive on what we get paid for. We do not get any grants or support from any government entity. So whatever we have in the hospital, lock, stock and barrel, staffing, infrastructure, capex, is all on our own. So we need to sometimes sustain ourselves, not to make big profits. The wrong notion goes out to the public and also to the government that we make a lot of money. It is not true, because a lot of money that is a lot of money that we get out of our business, it is channeled back into the business in order to sustain and also to keep up the standards, and which is, as I mentioned earlier, healthcare is not cheap.
Now, Dr. Kuljit, it's been a fascinating conversation. Thanks for being on the show, and thanks for being a great guest.
Thank you.
Now, I'm Brian Fernandez, and I've been speaking to Datuk Dr Kuljit Singh, the president of the Association of Private Hospitals of Malaysia, on Biztech's Health and Wellness Show. This video will be on our Facebook and LinkedIn sites, as well as our website, www.biztech.asia. Please subscribe and like our Facebook and LinkedIn platforms as well. Thank you very much for tuning in.